So the plan for my talk, be a few comments on the problem which already made by both me and Fayaz. But this is something that I would probably repeat 1 million times wherever I go, because the problem is not fixed yet. Then I'll go through one of the cases that I saw only recently, and key points that I regard as the relevant in clinical history, and then how I tackle this, and then I might spend some time on what can you do in future, and open the talk for discussion. Migraine is common, as I said. The stigma, misdiagnosis, and cost to the economy globally is enormous. This is in fact nothing new. Even if you look at the Buddhist literature, if you remember the Lord Buddha's time, when Jivaka was diagnosing headache cases for one person, he said that if I don't operate on you, you are going to die in 1 week. And for the other patient, Jivaka said that I don't have to operate on you. Basically, primary and secondary headache disorders. I'm sure migraine would have been fairly common even at that time. Already mentioned that chronic migraine is the worst. This is the most underdiagnosed, worst managed medical disorder. And I practice in a city where our headache society membership, more than 50% live. That's sort of a cream of Australia, if you like, when it comes to neurology. In that city, if I see this on a day-to-day basis, there's a problem in the world. That's why I said to you that it's never enough to go through this. Globally, the psychological things that we talk about, medication overuse, remain very high in this. Yet, once you get into this, this is one of the most rewarding brain disorder to treat and get involved as a clinician. Most days, those of us who are getting towards the last 10, 15 years of our practicing life, we go to bed knowing that we might not wake up the next day morning, especially those folks like us who sleep very little. But we go to sleep with a very satisfied mind, having done what we could do so far. Almost everything that I mentioned, I published in peer-reviewed journals, so nothing I mentioned out of just my head that had not been peer-reviewed and published. So case, 26-year-old IT professional, right-handed, 16-year history of sinus headaches. 3 very well-known surgeons operated him for surgical treatments in and around Melbourne with absolutely zero benefit of them. He came to see me from the other side of Melbourne. Melbourne is a big city with about 200, 300 kilometers from one end to the other. I practice on the poorer end of the city, close to the airport, with probably one of the most culturally and linguistically diverse communities in the world, as our constituents represent 166 countries in the world. So he came from the other side, which is regarded as the more posh side of Melbourne, because he heard that the neurologist with the funny surname has cured his friend's sinus headache. In detailed history, it was pretty clear that his headache syndrome is a headache syndrome with a lot of features. Like you know, this is Kandy. You have the Acelapera here. I don't know whether you still use elephants to the transfer logs and other things. I used to remember 2 types of elephants in this world. Those elephants who are well dressed and the very sort of flamboyant who are working in the Asala pageant, and those elephants who are pretty naked, hardly any flamboyant thing at all, but they are the ones who are actually doing the work, not just the pageant elephants. So the migraine, if you put sort of headache analogy, it's like a pageant elephant. It's a headache syndrome, but usually with a hell of a lot of features, not a sort of a very featureless headache. It would be correct for us to say that that's the only headache syndrome with so many features, isn't it, from various decorations that they describe as sort of a five faces these days. Despite he had access to some of the top-notch surgeons and physicians in the world, the Australian health system is one of the best health systems in the world. He never had a diagnosis of migraine. He was seen by a couple of neurologists also, still he didn't get a diagnosis of migraine. This is, as I said, this is in a city where Australian New Zealand Headache Society, more than 50% members live and practice. You could imagine the plight of other folks. We are not alone. If you look at the catchment area like Mayo Clinic, which is one of the most expensive health systems in the world, with top-notch physicians and surgeons in the world, all your Hollywood superstars and probably politicians other than Sri Lankan politicians, they go to Singapore. They go to Mayo Clinic thinking that that's the best treatment. In Mayo Clinic, if you have chronic migraine, only 4.5% would ever get a diagnosis of chronic migraine and very simple advice on prevention. So we got a problem. I think the key thing to untackle that is now I believe headache medicine is the hardest subspecialty in neurology. I'm not saying this to discourage you. It is hard to dissect a good headache history. These days, if I am interested in bringing a new neurologist as a consultant to the department, our departments are multi-specialist departments. I got 14 neurologists in my department. We share 3 salaries among us. When we hire somebody, I normally give them a headache patient to see how they are dissecting them. If they did well, they would have a job in my department. It's a democratic place, by the way. I don't single-handedly choose them, but as the head of the department, I have some say of who is coming in. You have to ask the right questions in a manner that will elicit the information which will help you to come to the diagnosis. So these are some of my terminologies. I clearly talk about headache days and crystal clear days rather than just headaches. You would be surprised to hear a person who had absolutely no crystal clear day for the last 30 years, in other words, headache day every day, a person who swallow painkillers. We got rid of codeine-containing medications completely from Australian markets 4 or 5 years back. About 4 or 5 of us got together and lobbied the government, and we got rid of that. Thankfully, we don't have that problem anymore. But yet they still swallow other pills, paracetamol, ibuprofen, etc. So we talk about medication days. You'll be surprised to hear that even after 30 years, if you ask, how are you, Mrs. Smith? How are your headaches? I don't get headaches. Oh, you're lucky. So you never had headache. When they pause and they said, you mean a headache? Oh, I get a headache. How often? Every day. How long? 30 years. Why didn't you tell me first? Well, I'm fed up because I told about these headaches for like 100 doctors. Nobody's interested in it. So now I thought that these headaches are part and parcel of me. So it's not worth even mentioning. So you have to bring these headache days and crystal clear days. Also remember, most headache patients have given up their hope. They have seen by multiple doctors, either family, friends, or hospitals already. And there are a bunch of people who basically come to you with zero hope. As you know, whatever the specialty that you practice, when you deal with a person with no hope, I spent 2.5 days since I came to Sri Lanka. I visited some of the most rural places, including some of the medical centers where you have no access to mobile phones, you have not spoken to your girlfriend for 6 months, and you have no way of communicating with the rest of the other world. The only textbook that you can see in the medical center is old Oxford Handbook of Clinical Medicine. And this is a person with basically no hope. You still have to resurrect some sort of desire to keep going as human. Therefore, as clinicians, we have to be patient. You have to establish rapport. You have to somehow improvise your wording and find the way to communicate with them. And always remember, most of your patients have not been to a medical school or headache master class, so they don't know how to give you a headache history. You are the one who should know how to get a headache history. On the other hand, I think we ourselves are culprits too. We often lack interest and get frustrated by seeing headache patients. You get a bit of a tingling if you are the senior consultant. If registrar tells you that next patient is a patient with headaches, you almost feel like, do I really have to see that patient? The most clinicians, with all due respect, they don't know what to look for and ask only a few questions. And more often than not, they walk away by inducing patients' erroneous self-diagnosis. I'm having headaches due to my husband or my wife or my children or Rajapaksa regime or Vikramasinghe regime or whatever the thing that is causing stress at that time or refractive error stress. We can do better. We can do better. It is a joy to do better, in fact. We need to train ourselves to take histories and spend time and be empathetic with patients and try and understand their misery and try and help them. Patients generally respond to physicians who respond, someone said. And as someone said, listen to the patient. Quite often he or she is telling you the diagnosis. I normally ask about medication use, acute medication use days. If time permits, I talk to the family members too. I do ask about disability. It's interesting to see if you ask the question, if you have noise sensitivity or light sensitivity, they would say no. Then if you ask the next question, so what do you actually do when you have a headache? Do you become hyperactive and move up and about and agitated and restless like in cluster headaches? They say that I'm absolutely not light sensitive, but I like to keep my eyes closed and draw the curtains and shut my eyes. So that is light sensitivity. Those people who say that they're not noise sensitive, they shout at their children or ask them to reduce the volume of the radio or television set. Also, always be vigilant about secondary headaches because migraine and tension type headaches are common. We are talking about billions. They are the one who are going to get subarachnoid hemorrhages too. They are the one who are going to get brain the bleeds other than subarachnoid hemorrhage, meningitis, etc. also. So always keep your feet on the ground and be vigilant. It doesn't mean that you have to do CT scans and MRI scans and whatnot all the time, but get to the story. As someone again said that you have to think. This is one criticism against neurology. Those people who say that neurology is hard, I would challenge that neurology is one of the easiest subspecialties in internal medicine. But the only difference is in neurology, you have to basically focus and keep thinking as you go. Whereas other subspecialties, you can think about your girlfriend or boyfriend or children or and still elicit stony dullness and hear the murmurs. Whereas in neurology, you have to keep focusing and keep thinking as you go about the differential diagnosis and different diagnoses, etc. It's worthwhile developing your own the mental or physical algorithm, how you plan these things as you keep doing those things and take histories and physical examination in a targeted manner rather than just fishing, thinking that you would end up with a diagnosis if you keep asking questions. As I said earlier, correct diagnosis is the way to correct treatment. Otherwise, you make the wrong diagnosis and you offer wrong treatment and contribute to ongoing misery. So a few other mandatory questions. You will have access to my slides later on. Don't forget to ask why they came to see you on that day. What were they expecting to get out of that particular consultation? And is there anything else that they wish to tell you that they forgot to mention on that consultation? This is basically typical patient-centered approach in any subspecialty in medicine and very relevant in headache disorders also. So these are some of my other standard questions, the duration, the frequency, the site, the duration of each attack, whether they're short-lasting or long-lasting. Professor Fayaz already told you that the important piece of information, how long does it take for the acuity, so that you can choose a particular acute therapeutic option, long-acting or short-acting. That's why you need to elicit those information to sort out the correct treatment, the severity, and other accompaniments. If you Google phases of migraine, you get to see 5 phases: interictal, prodrome, aura, headache, postdrome. This is only the tip of the iceberg that you see. The symptoms on these lines go on. The best way to remember is, you're all very familiar with Alice in Wonderland book. It is said that Lewis Carroll suffered from migraine, and most of the things that he described in the book, including the rabbit hole that he emulated from Oxford University main hall, one of the halls, the symptoms of migraine that he did suffer at that time, either part of prodrome, aura, or acute attack, or headache. Unfortunately, he probably would have been the only person who made money out of migraine. The cutaneous allodynia is common. I remember when I did the first Australian movie in migraine, which is available through YouTube, which was done by one of the Sri Lankan movie maker while she was living in Melbourne with her husband, a plastic surgery fellow in the nearby hospital. She told me that one of the characters' mum was I don't know how many of you have made movies, I've done few. You basically, to generate a movie, you have to do a lot of recordings and then you edit them to get to the story. So as we were going through video clips, she has removed one of the segments where mom was saying that normally as a mom, you go and give a hug to the daughter, but I can't even give a hug to my daughter when she was in the middle of the headache. So my editor has cut it away and I put it back. That is because that's cutaneous allodynia. She is literally describing the sensitized scalp and not being able to touch. The big thing that I mentioned there is manifestation of that. And again, the list go on. Don't forget to ask about disability. There are a whole lot of the tools available, and essentially what you are asking is with your work or household activities or school during last 3 months, missing that performance and the disability created by that. So the next, the couple of questions are essentially going through that. I won't go through them in detail, but you can get the idea. So the family, social, and leisure activities, and then you can give a score by putting those 5 questions and giving them a number. You created this thing called Midas score. This is how migraine is becoming one of the most disabling disorders globally, as number 1 for women, number 1 for those people who are less than 50 years of age worldwide, and number 1 across all ages, across all sexes in some countries like Australia and New Zealand. Don't forget to ask about the interictal status and various maneuvers that are associated with headaches also in the history. So once I have done that, then we pull together one side of my screen and I tell them that I do suffer from migraine, but in my case, my migraine is basically pushed to one corner in the brain, probably 360 days per year rather than the next 5 days. Whereas the patient on the other side with chronic migraine, it's a storm in the brain, pretty much 24/7. So we then establish a sort of basic, simple explanation of my way of explaining where we are at that time. When I tell them the plan is for them to come to where I am, If they choose to become a neurologist, they could become a neurologist. But what I mean is to have as many headache-free, as many crystal clear days as possible. I basically tell them that both of us have to team up from three angles: lifestyle, over-the-counter stuff that we can purchase, and prescription stuff. In Australia, we have at least 5 over-the-counter stuff that are supported by at least 2 published peer-reviewed research papers, and prescription stuff by at least 2 or 3 published peer-reviewed papers. So when we establish something, we have to make sure that others have done the same that we have done, and multiple groups confirm what we say and believe as working before the rest of the other world accept them. That's why I mentioned those 2 things. So once I go through things in detail, the 100% the response is now they are seeing me as their 10th neurologist or 15th neurologist. Most of the time they have seen by many senior folks than me earlier in my clinical life. Now I am also becoming that level, unfortunately. So the response is, Doc, does this really work? It works all the time. This is from the Professor Fumihiko Sakai lecture that he did for the Arch Congress that we ran a few months back, where 1,400 Asian neurologists attended. The paper is available, and I can provide the paper later on. I'm doing a more elaborate talk on this in Colombo over the weekend that I will warmly invite you to join. Essentially, when he did the work among 70,000 workers, this sort of approach worked almost 90% of the time. It's remarkable to see how much the life that we can change by spending time and empowering our patients. So the key things that I would like to educate my patients is headache-based crystal clear days, 5 phases, medication-induced headaches, and basic principles of acute headache management that Professor Fayaz elaborate on you, hitting hard, hitting early, right dose, right route, so that we avoid them going into chronic migraine and medication-induced headache as much as possible. I basically tell them that you have to know about headache medicine just as much as I do if we were to win this battle. So the lifestyle things we basically can remember as seeds: the sleep, exercise, eat healthy, drink healthy, diary, knowing about chronic migraine, medication-induced headache, and crystal clear days, and managing stress levels as best as possible with whatever the thing that is working for you, except things that are harmful for you. For most of these things, there is reasonable evidence, but you wouldn't say that level 1, the class 1 evidence, but at least for some, such as exercise, there's at least one research paper saying that if you walk at least 45 minutes per day for 5 days per week for 6 months, your headache reduction is just as good as you taking topiramate or Topamax 200 milligram daily. In my book, I got about 3,000 chronic migraine patients. Only 2 patients I managed to prescribe topiramate beyond 200 milligrams. Others, it causes side effects, the word finding difficulty, the cognitive issues. So the moment that you bump the dose up beyond 50, you get multitude of emails and your secretary is bombarded with a whole lot of phone calls. Again, you will have access to my slides. I'm not going to go through. This audience doesn't need how to advise on sleep hygiene, how to advise on exercise, how to advise on healthy eating and healthy drinking, the importance of diary, and the stress, except the very useful resources, especially for a country with a whole lot of Buddhist philosophy. If you put philosophy into practice, that's one of the best ways to deal with the stress. But unfortunately, most of the time, we don't practice what we preach. This is a colleague of mine who has visited Sri Lanka virtually a couple of times, and she has put together a very decent collection of the psychotherapy talks that you can download freely from internet with no cost, but they are all in English. The other YouTube link that I have done is one of the old British physicist, now turned a Buddhist monk from Perth. He has a series of talks on how to deal with stress. Absolutely hilarious and a whole lot of good jokes, but good the principles of living also, because most of you live in as if there's no hope for this country. I can tell you that your country has a better hope than where I live. Seeing how the sort of things are moving along. Nutraceuticals, most of the nutraceuticals that I mentioned has at least one research paper supporting their use in the preventative approach. I normally prescribe the recommended highest tolerable dose for at least 8 weeks before we give up. Vitamin B2 about 400 milligram, magnesium about 500 milligram. The rest of the other things, when you go through any guideline, you can see the correct dosing. Prescription medications, we have about 21 the medication types from antidepressants to antihypertensives to CGRP, monoclonal antibodies. We don't have as much neuromodulation devices as Professor Fai has shown, but we have access to a couple not supported by government reimbursements and the variety of nerve blocks also. So, as I said, I wasn't trying to give you a list of medications that you can prescribe with dosing and this and that. But for me, every win that I have done on a large number of migraine patients, I have done that by team game, by working with them. You need them to be on par with what you wanted to do. They basically need to know just as much as you know about how brain works and how the preventative medication work and use analogies as much as possible. When we talk about medication overuse headache, I tell them that it is pretty much like when your house is on fire. When your house is on fire, when you ring fire brigade, if they bring 8 bouncers with water, that's like 2 days per week acute medication use. But from 9th mouse onwards, if they're bringing gasoline rather than water, you pour that gasoline into your house that is on fire thinking that it will control fire. It's not going to happen. It's going to destroy the house. This is exactly the same way that too much medication use work in the medication overuse headache. Unless you get your patient on board with that, they're not going to do what you wanted them to do. I, as a migraine sufferer, if I have 5 or 6 meetings next day that I need to attend, can't take leave. If I got a headache, if I'd done things by the book, if I couldn't get rid of my acute headache within 2 hours, the chances of me popping every 4-hourly pills are significantly higher than not. So this is why educating your patients and correctly diagnosing and empowering them and putting things on the table and choosing preventative approach together is going to work almost all the time. There are patients with refractory headaches, but this is not the time to talk about that group. I think we're going to talk on that later on. I'll probably stop here. But again, my invitation to you is whoever you are, just be interested in headache medicine and you are basically stepping into a very rewarding career. It is hard work, but it is definitely rewarding. You get better at dealing with your own life and you get your patient becoming better at dealing with their life also. Thank you.